Good evening, everyone, and welcome. I'm Melissa Wilkinson from the Primary Health Network Education team. I'd like to acknowledge the local custodians of the land in which we're meeting on this evening and honour elders past, present and emerging. Thank you for being with us this evening. We've got a great topic, telehealth in allied health. I'd like to thank both of the presenters for being here with us tonight. Just a little bit of housekeeping. We will have a poll at the end. I strongly encourage you to please complete that. That information gives us data and helps us plan for future education events. Also, we're being recorded. A copy of this will be in the Education Library in the coming days, so you'll be able to access that along with a copy of the presentations as well. The Q&A box, the questions box, is there for you to utilise, and we're really happy for you to be able to do that. We'll have the time at the end of the session where we'll get to those questions, so we'd like it to be interactive as possible. So I'm going to hand over to you now, Jason. Thank you, Jason, for being with us. Jason's our IM IT manager at the PHN. Welcome, Jason. I'll hand over to you now.
Thank you, Mel. Hi, everyone. Welcome to our Telehealth in Allied Health. Assuming you all can see my screen right now with my slide presentation.
All good.
Okay, so I'll start by just acknowledging the traditional owners of the land that we're meeting on tonight, both virtually and in person, and pay my respects to elders past, present and emerging. So telehealth in allied health, this was, I guess, something that came up more so, as you all would know, with the onset of COVID back several years ago now, 2 years ago. At the PHN, we decided to come up with a strategy on how we could help get fair and equitable access to systems and equipment for all primary healthcare providers. At the PHN, we decided to promote just one safe, secure system only, with I guess, a vision that patients need to visit a variety of health providers, and if we can use one system in a perfect world, they only need to learn one system as a user as well from a patient's perspective. So at the PHN, we have promoted just the one system, but we have also, I guess, continued to work with our local health districts as well in the systems that they use to make sure that we're not flooding the market with a variety of systems. As we all know, there are many different products out there. We can also continue to advocate for access to all primary healthcare providers for access to telehealth and the systems as well. And I'm going to talk about some of that stuff a little bit later. We're also continuing to advocate for the subsidised access to video call systems through the federal government, which I'll also talk on. And like I mentioned, we continue to work with the LHDs in our footprint, which is obviously Central Coast LHD and Hunter New England LHD. Okay, so Telehealth Access. So what we have, the product we have chosen to use, and it was through a process of actually, I guess, looking through a whole heap of products, examining the products, looking at their pros and cons, what's safe, what's not so safe, what's cheap, what's not so cheap, etc. And we actually came up with a product called Health Direct. It's actually done by a company called Health Direct, and they're funded by the federal government. Health Direct Video Call, as the product's known as, is actually based on another product out there in the market called CoView. So it was actually commissioned by the federal health government through Health Direct to provide a free service to health providers during COVID. Currently, you see on my slide there, it's funded to June 22. However, it's been funded through 6-month periods and sometimes 12-month periods through the whole entirety of COVID, and generally around within a month or so before that expiry, the product is then funded for a further 6 months and so forth. Some of the features of this product: it has a waiting room. It gives you the option also to use meeting rooms, so internally you can use it, or you can also use it for team care arrangements. And the beauty of the waiting room side of things is patients can actually come into that waiting room, and then you can click on them in the waiting room when you're ready to start the consultation. And it obviously works with a variety of technology, both Windows, Mac, both Android phones, iOS phones from the patient end as well. So in terms of the product, the way you can get more information on that product, you can actually send an email to telehealth@thephn.com.au, and don't worry so much about the detail here, because you will have access to the slides after this presentation. That enables a registration form to be sent, or you can actually just ask for some more information, and one of my team will be in touch with you. If you're interested in actually purchasing or using the product, I should say, you can send the email to that address, and a registration form can be sent to you, which fills out number of users, names of users, email addresses, that kind of stuff, and then we do all the setup at our end. There's also access to a whole heap of training material and marketing material for both the clinicians and also your patients. So, for instance, if you book a telehealth appointment with a patient, you can then send them a little cheat sheet on how to connect. It's really, really simple. Currently, our usage across our patch, we have around 110 clinics using it, which is over 460 clinicians. We've also, one of the other things we've done, because we understand that, telehealth, and sometimes when things go wrong with information technology, you need to be able to talk to someone to try and resolve it there and then. And so we actually set up a help desk with our managed service provider that we use at the PHN. They're called Brennan IT. Their help desk number is listed there. Again, you can get that from the slides later. When you call that number, because you're directly not a customer, you need to quote HNECC, which stands for Hunter New England Central Coast --Telehealth Health Direct. That will ensure that you get looked after and ensure that you're not charged for any calls, etc. And we foot all the expenses there. We pre-purchase a block of support hours effectively. I get sort of monthly reports on that, and then I can actually top that up if necessary. And it's aimed at those without access to support for telehealth at all. They're generally IT support people, right? So they triage the issue and resolve if possible, or in some cases they may need to work with your own IT provider if it's something a little deeper in your network or your systems that need to be resolved. You can see a little picture there of a telehealth cart. That's something we set up in an aged care site or a couple of aged care sites that can be moved around from room to room. So if you're in a multi-room facility, or there's multiple clinicians there, you are able to get one of these carts that can be moved from room to room when needed. I'm going to talk about that right now. So telehealth equipment. So we literally have come up with this design, which is a telehealth trolley or cart. And we've come up with some equipment that actually goes with that cart, and we are working on getting some funding for allied health providers to try and actually provide some grants which may enable you to access these carts and equipment if necessary. You're quite welcome to purchase this stuff by yourself, and again, I can provide further information on what equipment we stock these carts with. But you can see there in the diagram, we use things, they're multi-height, you can adjust the height. These keyboards and mouse, you can clean them with antiseptics, etc., to clean them after use if they're used in a multi-user environment. The next slide I have is just a couple more pictures. So the cart by itself in the center photo there, along with another couple of pictures of the cart with the equipment. You'll see very closely on the left and the right hand side, the mouse sort of tucks in if they're being moved from room to room. Everything's kind of stuck down on the carts themselves, so they can't sort of fall off and break laptops and the like. And here you can see in this next slide, the cart itself, the laptop sits on top of the table, but the table actually slides out to hide all the cabling, etc. So there's no trip hazards. The power board's in there. We use what's called a dock, which everything plugs into, which allows the screen and the keyboard and everything to talk to each other. And basically that's all hidden away from view, and also for people to be able to touch, which us IT people tend to get upset about from time to time. That's all I really wanted to talk about tonight, was just give you a brief overview. As I said, if you're interested, go through the details of this slide after the presentation, or when you receive a copy of the presentation. I'm more than happy to follow up with you. Any questions from anyone?
None at the moment, Jason, but I'm sure there'll be some coming through for the end of the session. So if anyone has any questions, please pop them into the question box and we'll get to those at the end. Over to you, Amy. Thanks, Jason.
Okay, thanks, Jason. Can you see my screen?
Yes, all good.
Excellent. Okay, so I just wanted to start off by also acknowledging the traditional custodians of the land that we're meeting on, and also pay my respects to elders past, present and emerging. And now, as you can see from my slide there, I'm just hoping to have a bit of a chat to you about telehealth in allied health, and have a chat to you about how the Recovery Station team has embraced telepractice or telehealth. Here's a bit about the items that I'm going to be talking to you about today. So first of all, talking to you a little bit about Recovery Station as a practice and the different professions that we engage, the regions that we cover and the types of clients that we see. A little bit about how COVID has impacted on our telehealth adoption, and how we manage that, what's been working well for us with regards to telehealth and perhaps what didn't work quite so well across the different professions, and how each different profession has been using telepractice, and how that's changed with some of the easing of COVID, what the key benefits we've found have been from using telehealth, and what maybe that looks like in the future for us, as well as maybe some tips that we've discovered from using telehealth. So that's a bit of a picture from our last training day, a bit of a fun picture of the Recovery Station team. And just to talk very briefly about our values at Recovery Station that really define us as a team and how we take care of our clients. And this is a bit about what we feel should embody our day-to-day practice delivery, that it should come from a place of genuine empathy, respect, compassion and care for all of our clients, that we should always have a strong desire to achieve client-centred outcome, that we should always have a focus and commitment to continual improvement towards best practice, and that we should always be practicing as a supportive and professional team. A little bit about our team breakdown. We have over 120 staff at Recovery Station, and we're spread over the Newcastle, Hunter, Central Coast and Sydney region. So the disciplines that we include at Recovery Station, we've got functional OT, and that includes driver training OTs, as well as complex home modifications occupational therapists. We also split off and have our mental health services, which include mental health occupational therapists, mental health social workers, physiotherapists, exercise physiologists, dietitians, speech pathologists, and allied health assistants. So my role at Recovery Station is one of the clinical managers, and I primarily look after the mental health team, which is the mental health OTs and social workers, the PEP team, our physios and EPs, our dietitians and speech pathologists, and our allied health assistants. So I'm actually an OT and mental health OT by trade. So our client types, we look after adolescents and adults. So primarily we're seeing clients that are 12 years and over. We look at that high school age bracket and over. We don't actually see any clients that are paediatric clients. Recovery Station previously did see paediatric clients approximately 10 years ago, but we identified that really there were other services that ideally specialised in the paediatric area, and so we would refer any paediatric clients over to those that specialise and wholly and solely see paediatric clients. Our focus is on ageing and disability clients who are funded through NDIS, Veterans Affairs, iCare, home care packages, insurance and private funding. So we receive our referrals from that broad range: hospitals, general practitioners, other NGOs, care organisations, self-referrals, family members, all sorts of insurance agencies. And we're really providing services to clients with both physical and psychosocial disabilities, as well as then focusing on re-enablement for our ageing clients. So that's just a bit of a snapshot about us at Recovery Station. So now looking at how COVID has really impacted on telehealth. We've always had the capacity and offered telehealth to our outreach service clients, but COVID really highlighted the vulnerability of so many of our clients. For many of them, their usual services basically stopped when COVID really hit. And that was when we particularly saw that first lockdown period. Our largest portion of our clients are NDIS clients. And so what we were seeing for many of them was that their day programs ceased. For a lot of them, even their still accommodation or respite services and those sorts of things were saying these clients have to return to home. And so they were going back to home environments with families that perhaps were not really able to provide adequate support and care, families that were really highly stressed. These people were becoming very isolated. They didn't have any access to in-home support services for things like medication, ADL services, cleaning services. There was no community access services. They were finding things like anything in terms of recreational activities was completely out. We were seeing a reduction in mobility, a reduction in overall physical capacity, endurance, standing and sitting tolerance. We were also seeing a really big increase in challenging behaviours because all of the routines were thrown completely out of whack. So we were seeing an increase in mental health symptoms. And for our clients that were perhaps non-verbal clients, very routine-based clients, our ASD clients, we were seeing a lot of challenging behaviours, just general deconditioning, skills loss. We were seeing dietary changes. And also we were seeing a really huge impact on funding usage. So plan utilisation for our NDIS clients when they were no longer perhaps going to day program, which used a certain portion of their funding, but now they were actually requiring more one-on-one funding rather than 1-4 or 1-6 funding. Their funds were being used either at a much faster pace for some of them or at a much slower pace because a lot of their other services were being cut for others. So suddenly it meant that for a lot of our clients, everything changed overnight. So we had clients and families in significant need, but we had to also balance not only that client need, but the need to maintain staff safety and adhere to the public safety orders, the public health orders. So over the last 2 years, we've had a large portion of our geographical catchment in lockdown as well. So as I mentioned, we're Newcastle and Hunter, then Central Coast, and then the whole of the Sydney catchment area as well. So if, for example, we had a Newcastle therapist going to see a Central Coast client, during that really large lockdown period for the Central Coast that didn't necessarily impact the Hunter and Newcastle, a Newcastle therapist would go to the Central Coast only if we could guarantee that that Newcastle therapist could then have 1 week's isolation for the therapist post-visit. So we had some very dedicated therapists that could say, yes, I'll go down to the Central Coast and do a day's worth of face-to-face visit with Central Coast clients because they desperately need that face-to-face. And then I've cleared my diary and I'll do nothing but telepractice. And I've pre-prepared and I've got all of my essentials booked and sorted out at home so I can isolate for a week at home after I've done that day's worth of visits. But you really do have to take that into account when you're sending your clinicians out of their local government area. So when you take all of that into account, maintaining your usual practice wasn't really sustainable and it wasn't safe, and we really needed to work out how to adapt that quite quickly. So in essence, COVID was the spark that lit the telepractice fuse for our practice. We had it there, we weren't really utilising it to its full extent until COVID hit. So I'm not going to tell you that it was easy. It really wasn't easy. Hence my little chicken little there. We could have just buried our head in the sand and gone, no, we're just going to wait, and everything's crashing down. But we worked out we had to do something. But it was new. It was new to the clinicians and it was new to the clients. And as you know, learning something new and really building a new skill, it's really scary. And if we talk about learning a new skill, we've got multiple different concepts or ideas of what learning a new skill, what that can look like and how long that can take. So somebody like Josh Kaufman, he will say, you can learn a new skill in 20 hours. Someone like, Harvard Business Review says it takes 6 months. Then you've got someone like Malcolm Gladwell, who talks about mastering a new skill, who says it can actually take 10,000 hours to master a new skill. We were expecting our clinicians to pick this up overnight and want to run with it. We were also expecting our clients to pick it up overnight and accept that we could provide them with quality service via a new platform overnight. So it was also coming at a really scary and uncertain time when there was lots of fear about everything, lots to deal with. I mean, we were talking about a time when we were going through a global toilet paper shortage. They had enough to deal with, let alone somebody saying, we're now going to do your physio over the internet. Oh my goodness, there was so much other stuff to worry about. So we had a lot of skeptics, and I'm not just talking about the clients. We had skeptics within the team. We had technophobic therapists. We had technophobic clients. We had technophobic coordinators of support, therapists, clinicians, GPs, specialists, everybody. And then on top of that, we had funding bodies that weren't keeping up with the changes. And I'll talk to you about, in particular, DVA in a few minutes, because DVA was probably one of our slowest ones to really get onto the bandwagon of telepractice. And then we also had some people that were thinking, COVID, it's just a flash in the pan. We're going to wait it out. This lockdown thing, we're going to wait it out, and we'll wait and we'll see when the therapist can come and see us face to face. So for a while there, nothing really happened, and it was bumpy. So for us, we had to work on, first of all, settling on a technology platform that met our needs, that was client friendly, that adhered to all the privacy laws. We had a few bumpy starts. We ran a series of staff workshops to ensure that all of our staff were trained in the use of Zoom, which was the platform that we eventually settled on. We had to adjust our service agreements and ensure we knew how to document all of our interactions. We had to identify appropriate billing and coding within the funding bodies we worked with and set up our software accordingly so that we could bill appropriately. We had to adjust our workflows so that staff knew how to create and manage a telepractice appointment from beginning to end. And then we had to introduce our clients and referral partners to telepractice. So it definitely wasn't an overnight process. So, yep, there were problems and potholes. At first, we had quite a few cancellations. We had tech dramas, which was why we had to offer different platforms. Were we going to go Skype? No, there was problems with that. Were we going to go 3CX, which is our phone system? No, there was problems with that. Were we going to go Google Meets or Google Hangouts? No, there was problems. So we had to swap and change until we worked out what was going to work. As I said, clinicians were doubtful about what they could achieve over the medium. Referrers were doubtful about what they could achieve or what their clients would get out of working in that medium. So we had to then go back and make adjustments, and we had to really raise awareness about what we could do. So we actually instigated having meetings with each of our disciplines every 2 weeks that were discipline specific to share what worked and what hadn't. And that was all about going, what were your quick wins? What worked? What didn't work? How did you address those concerns with that client? What wording are you using to make them feel comfortable? What have you discovered within this medium that made it feel better, that made it feel more comfortable? So we created resource folders for each discipline to share what telepractice specific resources had worked really well. So they weren't reinventing the wheel each time. It was, okay, what have you already created around budgeting? What have you created around exercise? What have you created around this that worked really well? We repeated our training and videos for the slower adopters because we did have a certain group of clinicians that were going, yeah, I'll wait it out, that didn't really want to go through it. And we had webinar series for our referral partners, one that we titled Accessing Allied Health via Telepractice. And then 2 months later, we had one that was called Creating the New Norm with Allied Health. And that was understanding that, COVID's not going away in a hurry. We now have to help our clinicians, not our clinicians, sorry, our clients understand what this new norm is. And we also found that we had to add setup time to appointments, which meant that when we emailed out the link to the client, we would then say to them, you're going to get a phone call from your clinician. They're going to help you open your computer, go to that email, find the link, click on the link, and they will sit there on the phone with you until the screen's opened up. And then they'll hang up once you can see them on the computer with you. For some of our clients, they never got used to the Zoom, and it would be done via phone, and it would be a phone conversation. For some of our clients, they weren't comfortable in front of the camera. For some of our mental health clients, it took 3 sessions before they'd turn their camera on. For some of our clients, they still don't like the camera. They'd still prefer to do it over the phone. So it's about creating that level of comfort to suit the individual client, but still achieve the therapeutic goal that you're requiring. So I mentioned a little bit about the delay in telepractice uptake with DVA. COVID was first identified in Australia in late January 2020. The first peak was in March 2020. So DVA did not provide telehealth item numbers until the 1st of April 2020, after the introduction of the new MBS item numbers for our EPC clients. So by which point, many of our veterans were actually isolating with no family or service contacts. So it really concerned us, as we've got a really large veterans population. So we've got several thousand veterans that come to see us at Recovery Station, or we go to see at Recovery Station. So we actually created a welfare program to check on our veterans via telepractice, because by that point they'd already had about 6 weeks where they'd been in lockdown as those over 65 being told not to leave their home. So we were at that point able to create this welfare check program where we could call each of our veterans and actually go through a full welfare check with them, creating this checklist, going through all of these different items and ensuring that they were having all of these specific people coming in to deliver items to them, delivering their groceries, ensuring they had enough medication stocks, ensuring they had enough continence supplies, going through their falls programs, going through their exercise programs, checking on their social isolation, checking on their skin integrity, checking on their chronic disease management, their diabetes checks, all of those different things, and then setting up follow-up appointments via telepractice and working out, did any of them have video capability, either with an iPad or a laptop or a computer, or was it only going to be over the phone that we could actually continue to do this for them? And for many of them, it was really the big break that they needed, because for some of them, we could even set up that, sure, we couldn't go in and see them, but we could actually go to the front veranda and do things standing on the front veranda with them inside their house and us outside their house to make sure that we were checking that they were okay. So that was a big breakthrough for many of our veterans clients. So now I wanted to just touch on some of how it has worked for our clinicians, because I often know from working with our clinicians, it was, there's no way I can do X, Y, Z via telepractice. How can I do blah, blah, blah? And I agree completely. As a clinician, there's some things you cannot do via telepractice. I get that. And I think you'll see in some of my other slides, I talk about telepractice is part of, and it's one of the tools in our toolkits. It is not necessarily going to completely replace everything that we do. We need to have a multimodal approach to our therapy delivery. But you will see there, in periods when, for example, our clinic in Toronto was shut down, you'll see one of our physiotherapists in the top right-hand corner there is actually offering groups where she would actually do the exercise program in the clinic, and then it would be broadcast via Zoom to multiple different clients in their homes, and the different clients could see each other and socialize as well via that program of being able to see each other in their own homes going, oh, hi, how have you been going? How's this week been? Blah, blah, blah. So they'd have a bit of a chat for 5 minutes. Then they'd get in and do all of their exercises, seeing each other and seeing the person doing the exercises in front of them, who could then make corrections as to how they were doing their exercises. So you can see it in the one-on-one format over on the left, but you can also see it in the group format on the right. You can also see one of our lovely gentlemen in the middle there who is actually working on light meal prep with one of our OTs, because he's been able to position, he's got a laptop. We had several that had tablets and things like that, so like their iPad. They're able to position it behind where they've got their stove, behind where they've got their kettle or their toaster or their sandwich press or whatever, and they're able to go through that step-by-step meal prep. We were able to work with clients around budgeting, around things like money management, money identification, simple math skills. It's about using what the client has in their home, which is often very functional. We often are looking at how we can take out certain activities to them, whereas this really encouraged our clinicians to work creatively and think outside the box to what the client had in their home, which was often very functional. So working on fine motor skills for our OTs often became, grab that pair of scissors out of the kitchen drawer, grab that set of tongs, and we're going to work on how you're using your pincer grasp, how you're using your tripod grasp, how you're using your fine motor scissor skills, your pen and paper skills. Let's practice. We will email you through a form that you can print out, or we'd be prepared and we'd actually send out a workbook, and we'd send out that workbook in advance, and then we'd say, okay, today open your workbook and we're going to work on pages 2 to 6 in your workbook today, and we're going to do these activities. And we'd save a copy of that workbook onto the client's file, and we'd be doing pen and paper tasks that might be both cognitively based and be based on their fine motor skills and their pen and paper skills. So it's really excellent for doing things like you can do dressing retraining, you can do shoelaces, you can do all sorts of bits and pieces from a functional point of view. So it wasn't just around the idea of retraining skills. I often hear clinicians going, but how can I do things like mods home visits? How can I do equipment trials? We would often get the equipment suppliers deliver equipment to the front yard of the client, and then have support workers take equipment in and set it up, and be using their phones to show us videos or send us pictures. You can see here how pictures were taken to give us measurements, or we can actually do that via video conference. And that really enabled us to do things for simple home modifications and simple equipment reviews for many, many clients, particularly when our equipment showrooms were shut down. So we were doing that in many cases. For more complex equipment and for more complex modifications, as I said, it's not suitable for every purpose. So in this case, it was simple rail placement, and it was for a simple item of equipment like an over toilet aid. If it was something more complex, for example, a wheelchair fitting, it may have been that the rep would go out and then they would Zoom conference us in, and the wheelchair rep, if it was someone that was specialised in wheelchair fitting, would be able to talk us through that. If it was something where we felt we really needed to be involved and actually be there hands-on to be taking the measurements, then we would actually still go and do that visit with full PPE in place, and be making sure that we were adhering to all of the social distancing rules, unless we needed to actually be hands-on in contact with the client. So these are some of our mental health activities. So calming strategies, things like our we could do a lot of our sensory components, where we would actually send out strategies and ideas to family members or carers, and then actually get to do check-ins. We'd actually get them to keep diaries, get them to keep fairly good information, get them keeping ABC diaries of when behaviours were occurring, and then talk through that with the carer or the support worker, the family member, actually we found that a lot of our mental health clients really preferred telepractice, because often the idea of having somebody come into their home was really, really quite disturbing. And this meant that we were able to perhaps create that rapport from afar to begin with, which really opened up the floodgates after COVID started to ease. We would find the same way that with a lot of our mental health clients, it may take 3 sessions before they'd let us in the front door. In this instance, it may take 3 sessions before they'd turn their cameras on. And then they might actually take another couple of sessions before they do the walk around the house with us and actually show us their environment. And that's meant that once we've done that, they're now far more open to start doing those things with us. And we can actually then send them through these documents. We can talk through it with them using options like share screen. We can actually enable clinicians to share resources with their clients during sessions. They don't always have to send them out in advance. They can share the screen with the client during the session. They can actually use the whiteboard component in Zoom and get the client to complete things during the actual Zoom session on the whiteboard. So there's lots of activities that you can do during your session with the client where you're observing their function as well. So our speech therapists use it a lot still and literally loved it, because again, they could share screen with the client and they could be completing games, they could be using apps and things on shared screen with the client. They could be educating clients and carers around things like keyword sign. We used a lot of social story education and completed a lot of sharing social stories and social story education for telepractice. One of the big things that does not work via telepractice that we are really very definite about is swallowing assessments. So swallowing assessments where clinicians are required to palpate the throat and actually observe the swallow from the oral phase and chewing and then actually forming the bolus and swallowing. That really does require the palpation, and that's coming from Speech Pathology Australia as well. There has been modules around training care workers and support workers, but they have to actually be certified to do that. We, in our experience at Recovery Station, felt that our clinicians were far more comfortable with actually completing that face-to-face. And again, full PPE was worn during all of those sessions, including the usual mask, face shield, eye covering, gown, gloves, all of those sorts of things. So in terms of swallow assessments, that is something that we have always continued face-to-face. Our dietitians continue to really, really use a lot of telepractice, and they've always used a lot of telepractice. I think with the dietitians, again, it is something where they can share screen, they can send out a lot of recipes, they can do a lot of looking at food labels. So the telepractice component as well, when they're using particular apps and dietetics specific programs like FoodWorks. I don't know if we've got any dietitians watching, but FoodWorks is one that they use the same way with our physios. They're using PhysiTracks to actually send out the programs to their clients. It's meaning that using those types of programs, they can actually do for the dietitians their FoodWorks analysis online. They can actually send out the results of their FoodWorks analysis. They can actually send out recipes. They can send out diet plans. They can send out all of that information to the client. Then they can have a follow-up telepractice session to explain all of that, to review all of that. They can then do an online session where they're doing a weigh-in with the client, where they're doing a check-in to actually find out how they've been going with their recipes. They can actually do a scan of the kitchen cupboards and things like that with the clients to talk about which of these things have you got concerns with, which of these things are you unsure of. You know, let's have a look at what you've got in there for your healthy snacks. What are the things that you've got in there that you're not sure of if it meets your requirements based on what I've sent out previously? So there's still a lot of things that can be offered via telepractice. So that's some ideas about what we do versus some of the things that we know we really can't offer via telepractice, and we are still doing face-to-face with our PPE in place. And often we'll go out and we'll do our initial session via, or parts of our initial session via face-to-face, and then maybe follow up with some telepractice. So it might be a really good combination of models. When we're looking at our stats, to give you an idea, during our highest usage in April 2020, when we were all going into that lovely lockdown, we were still doing 80% face-to-face, but we did go up to 20% telepractice across Recovery Station. During another lockdown period that wasn't a full lockdown, say October 2021, we were up to about 8% telepractice across Recovery Station. So a non-lockdown period, February this year, we were about 4% telepractice, and then we're averaging around 4 to 6% telepractice. So you can see it is part of our business. It's not all of our business. It is definitely something that we will always continue to use, and it's something that we see as being part of our ongoing model. And you can definitely see, though, it went up to being a fifth of our business during lockdown. So for us, what we're seeing in terms of benefits, for our clients, it's meaning there's no travel charge for our NDIS clients, which means there's more time to offer physical intervention, report writing, more intervention sessions, all of those sorts of things. For some of our psychosocial clients, it was that gradual build-up of rapport and relationships. For those that might not have accepted somebody coming into their home and might have felt more confronted by that. It does reduce the fatigue on staff with no travel, and it really increases the safety around infection control, and it also increases the ability to see clients with challenging behaviours. So for some of our psychosocial clients, they've got significant challenging behaviours, and the only way that is appropriate to see those clients is via telepractice. It's much more convenient for some clients, and it's weather and COVID and traffic proof. So for some of our clients where they are in a different geographical area for us, it is the only way for us to actually see them, because they are several hours away from us. So we do offer a telepractice service to see them. For others, you know, we've had flooding recently and areas that have been cut off. So being able to offer that service to see them is fantastic, and it has definitely been COVID proof. It can also be really fun and social. So for some of our clients, they may have been less motivated to do activity, and our clinicians have found a variety of really fun ways to get them more involved. I don't know whether clinicians that are watching have used things like their filters and their backdrops and things like that with Zoom or the systems that they're using. But I've got, for example, physios that will do things like they'll get the client to do something facing them, and then when they get the client to turn around and do something facing away from them, to use their opposite side, the clinician will change their filter or change their background so that when the client turns around to face them again, suddenly they're wearing a pirate hat, or suddenly there's, you know, a lion standing behind them. And the clients are getting a real giggle out of it. And the client's like, I've never been more excited to actually turn around because I'm waiting to see what you're going to have next. So I've got clinicians that actually get really excited about downloading 5 new backgrounds each week so that they can surprise their clients at each session with what they've got going on in the background. I've got clinicians that are really excited about downloading new videos and things to put on their computer their file for that particular client so that they can have different rhymes, videos, songs to play with their client around personal hygiene management and things like that. So it can make it really exciting and enticing and fun for the client to be a part of. So, and it means that sometimes when everything else is stopped, the client doesn't have to miss out or go backwards. So I've got our Brady bunch there. The telepractice today, unfortunately, COVID's still not over and we're hearing that in the media. And at times it's our only way of providing service flexibility for both the client and the clinician. We've had clients move out of our region that perhaps, you know, started with Recovery Station and have said to us, we want to stay with Recovery Station even though we're moving to Queensland. Can we do that? Or perhaps they've just started with us at Recovery Station from outside of our usual service area. So telepractice may be the only way that we can offer them service. Our clinicians are also regularly participating in telepractice multidisciplinary case conferences and planning meetings with funding bodies. So actually being able to do that via Zoom has really opened that up a lot more as well. And as I was mentioning, many of our dietitians choose to actually have telepractice appointments with only one or two face-to-face visits per year and all of the rest of them as telepractice. Many of our mental health clients have found this delivery more comfortable for them and they've selected to continue portions of their sessions via telepractice. For some of our clients with challenging behaviours, it's the only way we can offer service safely. And we've got many of our regular therapy clients for speech pathology, OT, exercise phys or PT that have chosen to continue with telepractice now that they can see the benefits. And we still complete singular face-to-face visits for portion of the delivery, for example, the initial assessment, the swallowing assessment, the complex mods, that sort of thing. But then we offered this multimodal where we're doing a combination of visits. So telepractice for us for the future, as I said, there's some things that will always require face-to-face. Speech swallow assessments are just one of those things. But we'll continue to offer telepractice face-to-face and clinic visits going forward. And our aim is to always continue seamless intervention for our clients in whatever format is going to suit them and keep them safe and us safe. So I believe we'll always need that multimodal approach to care. And that will need to continue including telepractice. And that needs to be one of the tools in our clinicians' toolbox to maintain currency of practice and meet our clients' needs in their changing world. So the use of telepractice has encouraged greater creativity in many of our clinicians. And for Recovery Station, I think it'll improve flexibility for our staffing as well as outcomes for the clients and general job satisfaction. So I think we also need to advocate for ongoing funding allocation to telepractice because I think it will be disappointing if, as COVID restrictions ease, telepractice funding eases as well, because clients have now become so used to this being part of what's offered to them that it will be difficult for us to go back to service delivery without telepractice. So, and here's just a different way of looking at it, or how we tend to look at it now, is that we need to allow for many paths to our goal. If we fixate on just one path, for example, that face-to-face delivery, then we're likely to give up when that path's blocked. COVID presented a blockage in that path of delivery for us, and we had to find another way, which is what telepractice was for us. And I think that's been a really positive outcome. So thank you all for listening, and I'm hoping you've got some questions for me.
Thanks, Amy. That was really interesting. And it's great to see telehealth being utilised. And I guess that is one of the benefits that's come out of COVID, that we've gone across to these platforms and we can use those moving forward. So at the moment, if anyone has any questions, could you please pop them into the question box for me now? We do have one question in there, and it's in regards to bookings for appointments. So it's basically saying that for someone to be able to book an appointment or organise a telehealth, it can be a barrier for staff who usually do the bookings to know what the therapist would like, as only the therapist sometimes tends to know about the clients who would fit the best way possible. So how did you manage it and utilise that to decipher that with the bookings?
Yeah. So for
Yeah,
us, we actually got all of our clinicians to sit down and make a note in each client file whether the client would be suitable for telepractice or not. And that varied between disciplines as well. So when we had a multi-dis file, where maybe that client was seeing several different disciplines, there's actually a note in each client's file as to which disciplines they're suitable for telepractice and which ones they're not suitable for
great.
telepractice. So also for us, I suppose Recovery Station probably works a little bit differently maybe than other practices, in that the clinicians are supposed to recommend in their diary each week how they want their diary to look, so which clients they want booked in and how they want that delivered, whether it's face-to-face or telepractice. So they're kind of trying to indicate to their administrative assistant, their team coordinator, whether they would like it as telepractice or whether they would like it as a face-to-face visit. But yes, most definitely it does need to have that clinical feedback about whether this is suitable for telepractice or whether it isn't.
Great, thank you so much. If anyone else has any questions, you can pop those into the box, but it's looking like Amy and Jason, you've both covered it all so thoroughly that there's no more questions coming through, but I'll just give another minute for those and just remind you all that a copy of the recording and the presentation will be available in the Education Library after the event. Just give us a day or two to get those up for Michael to pop those into the library. Yeah, it looks like we've covered everything. Thank you so much, Amy. If anyone thinks of any questions later, you can always forward a question to myself and I'll send those through to Amy or Jason, depending on the nature of it. And that would be mWilkinson@hneccphn.com.au. And I just wanted to thank you both for being here with us tonight. Really appreciate your time. And thank you everyone else for being here as well. I know you're all super busy at the moment. And thank you for being here with us. So good night, everyone. Good night, Amy. Good night, Jason. Thanks for being here.
Thank
Good night.
you. Night.
Bye.